Hello and good morning from Basel, Switzerland. We are here at the ESOC TV session led by Microvention. My name is Jens Fiehler. I'm from the Hamburg University Hospital in Germany, and we are going to have three very good and interesting talks today about different aspects of interventional stroke research. And my first guest is Markus Mohlenbruch. Markus is Director of Neurointerventional Radiology in Heidelberg, Germany, and please.
Yeah, good morning Jens and good morning everybody. So the idea of this first interview is a little bit to talk about the Sesame results. This is a study which we conducted in Heidelberg, and yes, this is actually what we'd like to discuss. So here you see my disclosure. So for this study we received a grant from Microvention, but as you can see, Microvention did not have any influence on the study design, data collection or analysis. So the initial idea was to demonstrate that the use of SOFIA Plus catheter for direct aspiration as first-line technique is fast, safe and effective in patients suffering a large vessel occlusion in the anterior circulation. So you see that this is a GCP trial. So it was conducted in 14 European centers, and all the imaging were evaluated by an independent core lab, and also there was a clinical event committee to look at the different clinical events which you see later during my presentation. So this is the flow chart of the patients. You see that we enrolled 250 patients, and at the end we analyzed the data of 246 patients. Here are some baseline presentations which are, I would say, very similar to other registries. And the idea here of this registry was to look at two different catheters, so SOFIA Plus and SOFIA 5 French. You see that the majority of the patients were treated by using a SOFIA Plus catheter, which was probably related to the fact that most of the patients had an M1 occlusion or a carotid T occlusion, and only a minor group of patients, so less than 10%, had an M2 occlusion, and that was usually the indication to use a SOFIA 5 French catheter, or if it's a distal M1. You see that in 3 cases the SOFIA Plus was replaced by SOFIA 5 French because it was not possible to reach the occlusion.
So that's 1%.
Yeah, that was very low. Yeah. So in the majority of cases we were able to bring the catheter up to the occlusion site. But as you also can see here, that in a little bit less than 20% we used stent retrievers, and usually this was because of the fact that the aspiration was, let's say, not completely successful, so it was a bailout idea or strategy. If we go to the endpoints, then you see that, and here the primary endpoint of this registry, because when we designed the registry, that was in 2017, we thought we should still look for a clinical endpoint. That's why we used MRS CO2 at 90 days, and this was achieved in almost 64% of the cases. And then, of course, we looked at different secondary endpoints, like the recanalization rates after first-line aspiration, and then, of course, at the end of the procedure, and of course, the different procedure times. Very important, I think, is if we talk about different recanalization techniques or thrombectomy techniques, is to look at the first pass effect, which I think is a really good measurement to compare different techniques. And here you see that we were able to achieve a first pass effect with the SOFIA 6 French, so SOFIA Plus in 48%, and with the 5 French in 52%. It was even a little bit higher, but probably it was related to the fact that we use the 5 French more in distal locations, so distal M1 or proximal M2, and probably the length of the thrombus, which was also measured, was a little bit shorter compared to the more proximally located occlusions.
This is almost twice the first pass effect of the original first pass paper, which is quite impressive actually.
Yeah, so we also published, when we started with the SOFIA Plus, we published a retrospective data set. This was also a multi-center study, and it was actually very interesting that we already achieved very similar results, which are now confirmed by this GCP trial.
Yeah. And I think it's a different animal if you have very strict core lab readers who are not involved in the treatment and they want to find something.
Yes.
Then I think it's even a higher bar, but still very impressive.
Yeah, and if you compare these numbers to other registries, so this is, for example, the one from Mr. Clean. In this registry they also used SOFIA catheters, but also other aspiration catheters. You see that here they were able to achieve a first pass reperfusion in 54% of the cases, but it's a mixture of all different occlusion locations. And here's another one from Stryker. This is the cysts registry, and here the rate of first pass effect was a little bit lower, but I would say more or less the number which we observed is in the same range like other registries. If we go to the secondary endpoint of the recausation rate at the end of the procedure, so this is the combining technique of using a stent retriever in 90% of the cases. You see that these recausation rates are even higher within a procedure time of less than 40 minutes. And there was actually a nice drop of the NIH stroke scale at 24 hours from 14 to 4 at median. And here you see different safety endpoints, which I would say are more or less comparable to other registries, but very important, there was no device-related adverse event. So regarding the use of SOFIA 5 French and SOFIA Plus. Okay, so I have one case I'd like to show you, if this is okay. So that's a 78 years female patient. She presented with an NIH of 18 and a symptom onset within 3 hours. You see that this patient had an proximal M1 occlusion. So here you see the navigation of the SOFIA Plus with the help of a microcatheter, but there was no need to cross the occlusion. So after placement at the level of the occlusion, we of course applied aspiration for 1 or 2 minutes, and then in this case we retrieved the aspiration catheter completely, and this was the result immediately afterwards. And we also looked, and here we were able to achieve a TQ3 result, but what is interesting in this case, so this was the clot which was aspirated. You see it's an almost complete white clot with a red nose. So this is, I do not know if you can see my mouse pointer, but this is the proximal part of the clot. And usually what we know from different publications, usually these white clots are really difficult sometimes to retrieve by using a stent retriever, or sometimes also by using an aspiration catheter, but here it was actually a very short procedure. Yeah, so in conclusion, Sesame is the first GCP study using SOFIA and SOFIA Plus, and we were able to show that these catheters are highly effective and safe tools for direct aspiration in the treatment of acute ischemic stroke in the anterior circulation, but you can also use it, of course, in the posterior circulation. And these findings combined with other positive outcomes, and you will talk later on about another study, I think support the application of these catheters in the treatment of large vessel occlusions.
Yeah, excellent. Yeah, thank you. I think that's great data, specifically because of the high quality of the adjudication of the events, of the imaging and everything, and it's very imaging focused, as all of our studies. I have a few questions. So I think it was 63% good outcome, right?
Mm-hmm.
And what do you think was the explanation for the not good outcome in those patients? Because the inclusion criteria, you didn't show them, but we know that it's rather small core patients. Were they too late, too old, or?
Well, this is a good question. So basically, the inclusion criteria we focused on good patients at that time. So MRS is 0 to 1 and a time window within 6 hours. But even in this time window, because of, for example, poor collaterals, etc., even if you perform successful recanalization, you still have a number of patients which have a good recanalization rate, but still, let's say, not a sufficient MRS score at 90 days. So there are different reasons for this. We didn't look at this at the moment, but this would be, of course, something to focus in the future.
What was the rate of IV TPA on top?
The rate of IV TPA was a little bit higher than 40%.
Okay, that's interesting. Yeah, because if you look at the rate of good outcome, is even slightly better than Swift Direct, for instance, which seems to be a very high standard already. So more than 60% good outcome is really impressive. Is this something we should expect? Because we later are going to talk about the Etis registry, and the German stroke registry has something like 40% good outcome. Is this because of the highly selected patient population, or why are you so good?
I think that this is not the reason that we are so good. No, the reason is probably that this is not a real world population, because it was highly selected. This is, of course, a drawback of this registry, but again, at that time when we designed this study, it was still the idea to look at, let's call it, good patients, but now if we, of course, look to real-world population registries like the ones I showed with the first pass recanalization rate, so here the rate of MRS 0 to 2 after 90 days is significantly lower, because they included almost all patients. And this is usually the 60+%. This is something what you should not expect from your own data, but if you focus, of course, on patients with a low MRS at the beginning in a very short time window, then you can expect these results.
You reached approximately 90% reperfusion rate at the end of the procedure. So what were the reasons for the last 10%? Is there something we can improve to get the final step to the 100% reperfusion?
I don't think so that this is possible, because you have, of course, tissue which is gone before you start with your thrombectomy, and therefore there might be territories which have a low perfusion, and even if you recanalize the whole large vessel, there are, of course, a lot of tiny branches which are not visible by angiographic means, and this is something what we at the moment cannot really treat. Maybe in the near future there is an option to give some add-ons like certain medication afterwards, lysis, whatever it is, in order to improve this microcirculation. But I think there is always a certain proportion of patients where you are not able to achieve a TK3 result, even if you recanalize the large vessel occlusion location.
Yeah, this was the preparation for a much more ugly question, because there is a trend towards even larger bore catheters. 6 French was already crazy at that time when we started using it, and now we are going even bigger than that. Do you think this is necessary in the light of these results?
So you are right. So I think for M1 we are with a 6 French catheter we are able to achieve really good results with a high recanalization rate. I think the problem is more the carotid T occlusions, where the number here was low. It was less than 20% of the cases, but in these specific location, I think there is a chance of improve the first pass effect. And this is, I think, this is probably one location for the large bore catheters where probably there might be a higher chance of achieving a first pass effect compared to the 6 French catheters. And I think in the near future we will have the opportunity to use this 8 French super large catheters, and hopefully we are able to show even better results in this specific location.
Yeah, thank you very much, Markus. And I think it's a very important message to our viewers that we are not at the end of the road. And even if we already achieve a relatively high level of good results, it's not the end. So we are further working on it. And yeah, thanks again and congratulations for this effort that you led. Thanks, Markus.
Thank you, Jens.
Okay, our next speaker is from France, Foch Hospital, and he is a lot of things. He is the director of the stroke service of the Foch Hospital, and he's also coordinator of the Etis registry. And this is what we will hear now. And I think it's exactly the other side of the spectrum. So on one hand, we had a highly standardized study that was very much focused on standardized image patient enrollment based on imaging and clinical factors. And then we have, on the other side of the spectrum, the Etis registry, and we will learn much more about it now. Bertrand, welcome. It's a great pleasure to having you here in person as the coordinator of this registry. Please.
Good morning, and good morning, everyone. It's my pleasure to share our experience in France about using aspiration catheter SOFIA and SOFIA Plus. Please see my disclosures. What I want to explain is we have a network in France. It's a bit particular because we collect all of the endovascular procedures with a high level of completeness of the data. So it's a prospective, observational, multi-centric trial. And today I will present you our data about SOFIA use. Around 890 patients was treated by SOFIA or SOFIA Plus. And it was, of course, large vessel occlusion patients with a follow-up at 3 months. And we collect angiographic and outcomes, clinical outcome, and of course safety endpoints. But the originality is we collect all of the patients. So there is no bias. I mean, all patients treated in France, quite whole, since 2017, were included in the Etis registry and focus on the SOFIA and SOFIA Plus used today. It's of course national perspective. There is around to date, 37 centers in France for this study. There is 26 centers, and it's a very huge tool for publication when we start now. There is 3 main goals of our registry. First is why I'm here today, is just to give you some insight in terms of efficacy and safety on the SOFIA and SOFIA Plus devices. But we use our network for assessment of practice in terms of metrics for each centers, small, large, private, public. And again, it's an effective tool for academic research. For example, and I think it's very important for neurologists, is to collect the metrics. So we did it for each center in France. So you have the median in national fashion, and for each center you have all of the metrics before the admission and after the admission. So you already heard, and in terms of efficacy of thrombectomy device, and especially for SOFIA and SOFIA Plus, we agree it's very effective, but we have to bring the right patient, the right time very quickly, so we have to monitor the metrics we impose. In terms of SOFIA use in France, France is very, very user in terms of SOFIA, because most patients was treated with SOFIA. Around 61% of cases start with SOFIA alone or in combined with stent retriever. So we focus about 890 patients treated by SOFIA alone, and quite the same with SOFIA and stent retriever. And
sorry to interrupt, because I think this is very important for our conversation. So almost 2/3 of all patients in France are treated with a single type of catheter. This is correct?
Alone with SOFIA or in combination with a stent retriever, yes, but with SOFIA.
That's I think very special. Yeah, it seems to be very widely accepted amongst the colleagues. Okay, just to make sure that it's understood.
Sure. No, it's the right point, because operators in France are very confident with this kind of device. If we focus on these groups, I mean, in terms of occlusion site, it was very, usual, mainly M1 occlusion, 45. If we look at, sorry, because this slide is not so easy to read, but we compare SOFIA alone, we compare combined stent retriever with SOFIA, and after that, when it doesn't work, the operator used to change, and when we start with SOFIA, they change for combined approach. When you start with combined approach first, I mean, it's mixed between aspirations alone, stent, very few cases, or combined also. And as you can see, we used to employ additional treatment in terms of stenting or using fibrinolysis during the procedure. In terms of, as you see, 30%, 28%. Our purpose was safety and efficacy. So first, safety, in terms of complications, the rate was very similar that we published and other group published before, around 6 to 7% in terms of embolism in new territory, perforation or dissections. There is no difference between SOFIA or SOFIA plus stent retriever.
So the perforation, is it SOFIA related or any device related? So it's not specific, right?
It's not so easy to answer the question, because when you use combined approach, sometimes it's difficult to know exactly it's a stent or, so we cannot be sure that it's because of SOFIA or because of using a stent retriever also. In terms of hemorrhage, symptomatic hemorrhage, so quite, I mean, the rate is a little bit higher in the combined approach, but don't forget that this population is more severe, more proximal occlusion also, so I think there is no main message on that. In terms of delay to access to the clot, the delay is very short with SOFIA, around 15 minutes. In terms of delay, it's between the arterial puncture to the clot contact. So when we monitor this delay, we report 15 with SOFIA, a little bit longer with combined approach. And the third group is a mix of aspiration alone or combined without SOFIA. That means that also if you're using aspiration first, the time is shorter with the SOFIA.
Very similar to the COMPASS study where they had exactly the same observation. It's just quicker.
It's because, don't forget, during the night or using aspiration catheter, and especially SOFIA or SOFIA Plus, it's very easy. Because you don't have, I mean, I am neurologist, no operators, but when we discuss, and it's very easy because you don't need extra hands. It's in terms of navigability, trackability, it's a very effective device, so it's explained why the delay is shorter in terms of arterial puncture to clot contact time. When we look at the angiographic efficacy, again, we can start here, but now the TK2B3 is around 90%. Don't forget, in 2015, the first randomized control trial on thrombectomy, this rate was 71. So it's impressive to see the increase of 2B3 rate at the end of the of the procedure. But again, now our proposal is not 2B3 because 2B it's only more than 50% of reperfusion. So we need to focus on 2C3 endpoint and first pass because we know that it's directly linked to the good outcome. There is no main difference in terms of first pass effect between SOFIA 26, SOFIA plus 10, 27, and the rate of TK2C3 is quite the same, around 50%, and the rate of TK 2C and 3 quite the same, around 69, 64. It's very impressive because it increased a lot since the start of thrombectomy. If you look at a little bit more precisely in terms of occlusion site, you see that when the occlusion is more proximal, when the clot burden is higher, the combined approach seems to be better. It's been already published from ASTER2 trial, but there is other publication on that topics suggesting that operators should use combined approach for more proximal or higher clot burden, as we saw here in this study. And if we just try to have a look on the strategy in France from 2017 to now, to date, as you see here, first, aspiration in France was very, very higher. Mm-hmm. It was very particular in France. Okay. It's why we start ASTER trial also, because operator use to employ aspiration first. But now the trend is to be quite similar between aspiration and aspiration plus stent retriever in first line approach. And you see using stent retriever alone is very rare in France to date. A new message, it's about the evolution of first pass effect. You see 2015 and to date, 2022, the first pass effect increased a lot. And even, as I already told you that the rate of TK2B3, 71, and now quite to 90. So I think 90, it's a graal. There is, yeah. So the question now is to improve TK2C, to improve first pass effect, to use post-recanization adjunctive treatment. And if we look at the progression of the rate of TK2B3 with contact aspiration, we saw an increase of the performance of this approach from the beginning.
Quick question to this slide. We see that, as you said, it was an increase to 2018, and then it's a plateau on a very high level, because how do you improve from 90%? But what I see here is also that the confidence interval is increasing. Is there more heterogeneity? So there are a separation of the superstar centers in France and some maybe less well organized?
No, it's a good question. Again, our data are very broad in terms of type of centers. So there is, I'm not sure that it's only due to the experience of the operator, of course, but we include each year new centers. Okay. So the experience in this center are quite low at the beginning. So I don't know exactly. I think we get a plateau now.
Yeah, because it's extremely hard to improve from 90%. So as we all know, so that the last percent require the most effort. Yeah.
But again, for the neurologist, the message is, okay, thrombectomy is effective, and with SOFIA Plus, the rate is very, very impressive, but we have to get our patient very quickly, because we know there is a time-sensitive efficacy, so it's very, very important to short. And again, to date, the delay is very long. Yeah. For example, in France, between the admission time and the start of the procedure, it takes around 100 minutes. 100 minutes between admission and starting the procedure. So we can improve the device and everything. It's important. And with, as we saw with SOFIA Plus, we get very, very high rate of overperfusion, but we need to get more time for the outcome. And my last slide was just to focus on SOFIA in France, as we discussed. I was very impressed as I work on this topic about the use of SOFIA and SOFIA Plus in France. As you can see here, in 2022, it was around 65%, starting with SOFIA alone or with SOFIA plus stent retriever in France. So our operators are very, very confident with this kind of device.
Yeah, excellent. So, thank you. I think it's a very interesting insight into the real clinical practice. And again, I'm really impressed with the numbers here and with the widespread use of SOFIA. I have a few questions. So, number one, what was also interesting was this slide about the time course of the different approaches. You said combined. It's I think one earlier. Yes, this one. That the combined approach also kind of okay. The differences are very small, 51 to 47%. And you mentioned that most likely the combined approach makes most sense for the most difficult of occlusions, the proximal ones. But if you look at the practice in each center, and I think I saw a slide from another presentation on the Etis registry, there's quite a clear practice pattern. So some centers use stent retriever only, and some centers use combined approach in the majority of the cases. Do you think that this changed? So do you have maybe an idea about, because what we see here, we always assume that the practice in each center is very similar, but in fact there are centers who are fully on stent retriever only, that's what they do, and they will never change it. Do you have any idea on this?
Well, in France, starting with stent retriever only is very rare.
Okay.
There is no centers in France starting, very, very, very rare. So most of the time they use aspiration first or combined approach. And most of the time, if the clot is very proximal in terms of ICA terminus, for example, they use combined approach. It's a longer clot, they use combined approach. Yeah. There is no definitive answer on that because we try to give some insight from Master 2 trial, and there is a vector trial will be published soon, focused on combined approach. But most of the time, if the clot burden is very higher, they use combined approach, and it's why, as you saw here, you can see here the rate of combined approach increase. But as you know, it takes more time, a little bit more complicated, and what it's 2 EM and using a lot of devices, sometimes it's a little bit complicated. But now it's quite a plateau between the two approaches.
I see. And I think one of the beauties of the Etis registry is that you have, let's say, 4,000 or 7,000 patients in 2022, 23 alone. And I think this gives us a very good information about the practice pattern. And
I think it's it's an important point because if one of our goals is to evaluate new device, and I think it's very important to use contemporary data and not historical data. When I saw some performance global analysis, so using data from 2015, I think we saw the rate of improvement in terms of TK2B3 to first pass effect. So we need to use very recent data, and what we did in this work.
Yeah, and a particularity in France is the usage of MRI as an imaging modality in many centers. So I think in the rest of the world it's not done that way. Do you think this influences the practice of thrombectomies, selection of materials?
No, in terms of materials, I don't think so. In terms of using IV fibrinolysis, I think maybe, because we had a lot of information with MRI at baseline, especially in terms of positive lesion in flare, and sometimes neurologists prefer to avoid fibrinolysis. I think we have to be very careful about that. And the Germany group published a paper very interesting because it shows that there is a decrease of using TPA before endovascular thrombectomy and now. So maybe because urology thinks that, okay, thrombectomy is so effective, so I prefer do not take too much risk. I think it's an error, and we need to use TPA, especially in the very early time window.
Yeah, and why do you think?
Because I mean, now we treat more severe patients with larger volume. We talk in the randomized control trial, last and tension and Tesla and everything. So, and with late window. So, when neurologists have one contraindications, says before there is no alternative. Before there is only thrombolysis. So we push a little bit the indication. Now we have the thrombectomy. So sometimes we prefer directly go to the thrombectomy. It's a mistake. We need to use both.
Yeah. So there's definitely an added therapy effect, even if it's small, and most likely it's as you mentioned, there's this publication on 2 hours 15 minutes. Like it's replicating the IV TPA studies. That its IV TPA effect seems more time dependent than thrombectomy effect, but yeah, it's still there. So 100% agree with that, and so I think, that was my major point here. So again, congratulations for this effort. Thanks, and I think it's a lot of work, and it gives us a glimpse into what's going on, and we can learn a lot from it. And thank you.
Thanks a lot, Jens.
Okay. And then we go, I think that's a very nice transition as well to the more peripheral occlusions, where we have a higher effect, most likely from IV TPA. And the question is, do we need thrombectomy there? And it's my special pleasure to introduce Serdar Geyik. He's a professor of neuroradiology in Istanbul, and he will talk about distal occlusion and what he does with them.
Oh, thank you for the introduction. Yes, it's good to see you and be here. Hello, everyone. We are talking from ESOC TV studio today, and the recent topic after 2 wonderful talks will be distal medium vessel occlusions. Coming back to the distal medium vessel occlusions, why we are talking today about the MeVOs is the main reason is the incidence. 25 to 40% of the occlusions of the acute ischemic stroke is due to medium vessel occlusions, and if we think about the journey of the mechanical thrombectomy, the 5 big papers published in 2015, they're all related with the large vessel occlusions, and then the efficacy over the medical treatment was proven, but we have learned a lot starting from that day about the symptomatology, scales of the symptoms, and then imaging parameters, going advanced imaging parameters with the large vessel occlusions. But those studies did not include most of the case scenarios that we are dealing today, is like tandems, wake-up strokes, but the majority is, including the posterior stroke, but the majority is distal medium vessel occlusions. So when we come to the distal medium vessel occlusion, symptomatology is very variable. Why? The arterial territory is variable, like anterior circulation or middle cerebral arterial circulation, or the posterior circulation of the MeVOs are very variable in terms of the clinical symptomatology and the treatment techniques. When we go look at the data, we show that 50% of benefit is proven with the alteplase. Just to be secure, it's not, mechanical thrombectomy is not still yet proven to the distal vessels, but today we know that there are lots of studies ongoing, and then we know that there are published case series, and most of the world is dealing with the distal thrombectomy. Likewise, the LVOs, first pass effect is very important at the distal medium vessel occlusion treatment as well. Why? First pass is so critical, because if we don't have first pass, distal embolization gets 4 times more, and then the embolization into a new territory will be 3 times more if you don't have any first pass recanalization while doing your mechanical thrombectomy. So what they say is best clinical outcome correlates with first pass, but is it really true? I don't know. Maybe the worst clinical outcome correlates well with the distal embolization or embolization into a new territory, but it's both are the same in the direction. And then when we come to the ERIC retrieval device, what it provides to us for the distal thrombectomy in terms of technique, this is compared to the first generation stent retrievers, those are cylindrical in shape. This one has a different style. It is consisted of interlinked, independently turning cages. Those cages has at the lateral side large openings to get integrated with the clots. Likewise, the first generation stent retriever does. Plus, those cages has the possibility of capturing the clot inside the cages. And then in this way, there are spaces in between cages that the thrombus can drop inside the cages as well. So you have 3 different possible way of interaction. So we can add the case pictures. We can see that clot can be captured inside the cage or in between the cages or integrated with the cages. How we achieve that one is, when we deploy a stent retriever through a thrombus, we don't expect the thrombus get down inside by itself, right? We have to force it one way. The stent retriever applies an outward radial force, and then they get integrated. And this one, we have something to get drop inside the spaces between the cages. It is the aspiration catheter. When you advance over the stent retriever, then you shave the clot between the stent retriever and the wall, and then the spaces between the cages would be the dropping zone.
I think, may I ask a question? So the thing with the more distal occlusions is that you have more tortuous vessel in the periphery, and ideally we want to grab the clot as good as it gets, and at the same time to have as little friction at the vessel in order to not push too much traction force. Could this be an explanation?
Yes, that's 100% true. But if we don't, I mean, there are papers that proves that if you use combined technique, I mean, the proximal aspiration combined with the stent retriever, then you can shave the clot as well. Yes. The efficacy is much better than using single stent retriever or single aspiration. Combined is likewise the LVO. It's much better.
Okay.
And here is a case how it works. This one is large vessel and 1 occlusion, left and 1 occlusion, and then stent retriever is deployed through the M2A. Here's the aspiration catheter advanced over the ERIC retrieval device. So it's kind of shaving the thrombus between the wall and the stent retriever, and then that's the first pass result achieved ticket-free in this particular case.
Okay, I think that's very important to see how the SOFIA goes.
Advance over the stent retriever. Otherwise, those spaces in between the cages, they're not useful. They're not functional if you retrieve back. So, looking to the details, ERIC retrieval device at the cross-section has a star-like shape compared to the conventional first generation. They're aligned 360 degrees with the vessel wall itself, but this one has like star shape and the 5 points touching to the vessel wall, and then the rest is not touching to the wall, and the outward spaces are getting working as integration, getting clot inside the cage. So cages are independently rotating. What it means, they can take the shape of the curvatures easily, and as said before, there is soft outward radial force, then it target to not to stretch the vessel. Another case example here, M2 occlusion, single branch. After the M1 bifurcation, there's a sharp turn here, very sharp angle, and then Another turn here, it's kind of Z-shaped vessel. I don't understand how that thrombus went over that one, not their straightforward vessel, but things may happen, we know. And then look at this one, again, and one, and it's sharp turn, another sharp turn. This is the advantage of the independently turning curves, so they can take the shape of the curvatures much better than conventional cylindric type, because there's a unique body. So if you deploy it towards the curvature, they're not going to meant to take the shape of the curvature, but the vessel will be elongated or change the angle, which is very risky for the small perforators coming out of the vessel that we don't know. It's stretching, not that it's stretching, changing the angle even though is a risk factor for having subarachnoid hemorrhage.
So if we look at this branch, we are below 2 millimeters. And you use the ERIC 4x20?
It is 4x20. Let's look at after the recanalization. Okay. That's one of the advantages. Here we got the result, captured thrombus in the 3 of the cages. And then when we look at it, now it was pseudo narrowing or pseudo reduced caliber, let's say. This branch is not so tiny itself. No. Otherwise, we didn't talk about, because we have limited time, we didn't talk about the NH scale of this patient. It will not be high NH for this patient. But the good part of the stent reaver, you can use 17 microcatheter. It's not, I'm not sure that it's ready to use in all of the countries regarding the logistics, but here in our country we can select, either you can select 3 millimeter. After you a little bit give contrast medium, you can understand the diameter of the vessel, and then you can select your stent reaver size with the same catheter. That's another advantage from technical point of view. So our single center data regarding 50 patients, mostly those were M1, M2 occlusions. NHS was mean 14, and the aspects were 9 with the IQR 5 to 10. Our first pass results that we had achieved with the ERIC retrieval device was TICI3, 32%, 2C, 16%, having in the first pass excellent recanalization rate of 48. And then if we add on 2B67, it will be 58 in the first pass. I'm not talking about 2B50 anymore. I don't think that it's valid from now on, that 2B50 from success story. And then there are a couple of measures for the thrombectomy series. First pass rate, last pass rate with the same device, and then the rescue, need for rescue. Our final recanalization rate with the mean 2.2 pass was 44% TICI3, and then TICI2C more than 70, and then the TICI2B over 90%. The remarkable part of this procedures was 34 minutes mean procedure time. It was short, and most remarkable, I would say, the complications and adverse event part, because we didn't observe any device-related serious adverse event, but our subarachnoid hemorrhage rate was 4%. Published series are mostly above this. Why we achieved in this one? We have limitation, of course, single center plus 50 is not enough number, let's say, talking about a big series, but still having this percentage of low rate of subarachnoid hemorrhage, to our opinion, it is because of the conformability. Number one, LINX takes the shape of the curvature, and then number two, they don't touch the vessel at 360 degrees. They have only star-like limited touching point. Maybe, of course, it's hypothetically, let's say, it's occurring going for less stretching, less screwing of the vessel. It may end up like this.
Okay, cool. Yeah, congratulations for this series. 50 cases distal with the ERIC. That's quite impressive. So I think one question is, where does, maybe the easier part is, where does distal stop? Is there any place where we say, I don't go there?
Well, anatomically, I believe that there's nowhere that we cannot go at the moment anatomically, but we have to, that's a good question actually, we have to combine with the symptomatology and then the pre-op imaging. If you have an infarct and if you don't have any viable tissue to go for rescue, and then whatever you do, you're taking a risk.
Yes.
And we want to help patient. It's not our privilege to go M4, but we can. Can we? Yes, we can.
Yeah.
But if it is where to go, yes, we can.
I think the ERIC is approved to 1.5 millimeter vessel or something. So maybe we don't want to talk about what you can do out of the instructions for use, but theoretically you could.
Yes.
To do that. Yeah. And the other question is, where does distal start, or does it matter?
Oh yes, that's another. But you know, I would like to ask this question to you. Where does it start? Because you're more senior and more elected with this issue. Where does it start?
Yeah, I think it's. I would consider M2 to still be part of proximal. And what is M2? I would really go for the Fisher classification, where it's strictly geometrical. So as long as it's in the lower part of the Sylvian fissure, I would always consider this to be proximal. And so your case was on threshold between proximal and distal, and then more distal. So Sylvian point M2, M3. Then it's really and it's also getting more difficult. And
our case was not typically having a typical anatomical bifurcation. It was a single branch. So one of the discussion is, if there's a single branch, we take it as distal.
I think essentially it's about the volume of the brain that determines the volume of the vessel, that the flow essentially, and then with this the diameter. I
totally agree. And then it comes to the pre-op imaging facility. If you do a pre-op imaging that you can calculate the volume, then you can go on. I mean, you can decide. You can say something different, or if you go for plain CT that you cannot calculate the volume, then you can say something different. By the way, another discussion would be where the thrombus is. I mean, if it is occluded distal, let's say, at the junction of M2, M3, but you see stop point of the angio proximal M2 because it doesn't go to the thrombus point. So how come you rate it as M2 or M3? There are lots of concerning issue with the saying M2, M3. But M3 is definitely M3, or M4 is definitely M4, or A2, A3. There's a certain, and there's a concern about the M2. Distal M2 is a
distal
medium,
dominant M2. So I think that's really a difficult discussion. But I think it doesn't make a lot of sense anatomically, but it makes a lot of sense in decision making, because people will start saying there is no evidence for that. But the threshold in the studies, so for instance Hermes analysis and so on, was quite blurry. And there is a sub-analysis of Hermes when they said, so they analyzed M2s, and there was also therapy effect in M2s, but what exactly was the M2? So I think
there are high NIH M3s as well.
Yeah.
Would you go for that? Yes, of course, because high NIH.
You could even say NIH is not a good tool for measuring.
I don't want to dive in that.
So,
but in the beginning, what we say, I mean, symptomatology, scaling for the symptomatology, that's all we learned from the LVO, not from the DVO. But today, almost 1/3 of the thrombectomies or 1/3 of the acute ischemic stroke is the MeVO. So maybe we have to go for another anatomical scale, another clinical scale, and then another imaging algorithm for the MeVOs independently. And then when we say MeVOs, PCA MeVOs is not equivalent of the ACA or the MCA MeVOs, even though MCA may be divided into superior or the inferior.
Yeah, and even let's say you have the same symptoms, you risk hemianopia, and you have a 87-year-old who lives a wonderful life, but you wouldn't risk going there most likely. But if you have the famous 52-year-old lorry driver, you probably
yes.
would do it. So there are so many factors, and I think in the
Definitely.
end we need to have clinical judgment, but at the same time a bit more standardized guidance, as you mentioned, maybe different scales, something like that would help a lot.
And then at the end, still with any kind of device, let me say today ERIC case study is very good, but still we have the 50% of the success rate for the first pass effect. And almost same with the other device. Do we agree on that one? Is there a device that we can provide, let's say 70% or exceeding above the first pass rate? No, still not yet. Today we are stuck in around the 50s with any kind of mechanical thrombectomy device. But the good part is we are coming around the 100% within the total final reconciliation, let's say.
Yeah, definitely. So we have different aspects. So the technical, procedural improvement, exercise, clinical judgment, all this. And thank you for sharing your experience with distal usage of ERIC. So we are using it for distal occlusions as well, actually. But still, I learned a lot. Thanks.
Thanks for the invitation.
Thank you, Serdar. It was a great pleasure. And thank you very much for your patience and for listening to us. And yes, so it's now my role to conclude this TV session. And it was a great pleasure for me having all this spectrum from measuring the effectiveness of SOFIA in a very standardized fashion with external committees with a very good first pass reperfusion rate, very good final outcome. Then the overall experience in France with the, let's say 2/3 of the cases almost are done with the SOFIA catheter, which impresses me a lot. Very good outcomes, very good registry where we can learn a lot from. And then finally the final frontier, the distal occlusion, where we made a lot of progress in recent years as well, and we will learn a lot in the very near future, maybe next year at ESOC, with the distal studies being presented. Thank you very much, and thanks again for supporting this session to Microvention, and have a good day. Thank you very much.